Hello everybody, I'm Eileen McKenna. I'm the Associate Director for Nursing Policy and Professional Practice in RCN Scotland. I would like to welcome you all to our Student and Newly Qualified Nurse Annual Conference. The format of this year's conference has changed to a virtual event for obvious reasons, and we really appreciate you joining us for this session. And I hope you will also join us for the session on the future nurse education and the session exploring the impact of shift working on wellbeing and how to minimise that impact. Both of these are important topics, and it is your opportunity to get involved in the debates. The format for today is to hear the speakers' presentations and answer and then have the opportunity for the speakers to answer your questions. We want you to get involved using the Q&A function. The event has also been recorded and we will make it available on our website. RCN Scotland will be also tweeting during the event, and you are welcome to join in the conversation online using the @RCN Scotland hashtag at RCN Scotland in your tweets, plus the hashtag nursing and you. But before I introduce the speakers, I would like to take this opportunity to share with you some exciting news. RCN Scotland are today launching a method to capture the stories and lived experiences of nurses, nursing support workers and nursing students as they face the continued challenges of COVID-19. As you know, the World Health Organization designated 2020 the year of the nursing midwife, and this has been a year like no other for nursing staff and students across the country as you stepped up and faced the COVID-19 pandemic. Our priority is to support our members through this time and understand the impact of the current working environment will really help us to do this. We would like you to take 10 minutes to tell us your story. It doesn't have to be exciting or out of the ordinary, but it is important that we hear your experiences both professionally and personally. The tool to capture the data is called SenseMaker, which uses an evidence-based methodology and can capture and analyse large quantities of stories using both quantitative and qualitative methods. This will help us target local support and influence decision-making and policy. It will also create an important historical record of nursing in Scotland during a global pandemic. The process is quick and easy to use, and please be assured that your input is totally anonymous and we will never share your details. If you will have received an email with a link, please share your stories and encourage your friends to do it also. So I'm going to hand over to the speakers now, and I'm going to ask them to briefly introduce themselves. Today we have Dr. Richard Kyle and Benjamin Gray. So over to you.
Thank you very much, Eileen, and thank you very much for this invitation to come along and speak with you all this morning. It's very strange times to be doing this online. It's very unusual to be presenting online, but it's a great opportunity to come and share some of the work that we've been doing both in Scotland and in Wales. My name's Richard Kyle, and I'm Deputy Head of Research and Evaluation at Public Health Wales, and I'll just hand over to Ben just to introduce himself.
Good afternoon, everyone. Yeah, thank you for the invite. Yes, my name is Benjamin Gray. I'm one of the senior researchers within the Research and Evaluation team at Public Health Wales. I lead mainly on some of the employment and health projects that we do, of which we looked at nurses' health and wellbeing last year, and we're going to share some of the results with you today. Thank you.
Thank you very much, Ben. So I think we'll just make a start, and as Eileen said, do please feel free to tweet and sort of engage in the conversation so that we can share what we're sharing here with others. beyond the actual conference itself. It's always great for people to be able to engage through Twitter. So we've put both of our Twitter handles on everything as well. If you wanted to kind of ping direct kind of things to us that way as well, that's a good way of connecting with both of us. We've kind of called this presentation today "Halting the Environmental Emergency in Nurses' Health," and I think we'll come on to explain why we think that there is an environmental emergency within nurses' health. But I think the place that we have to start is exactly where we are right now, which is in the midst of COVID. And it's as Eileen said, you know, for all of you attending today, these are very, very strange times. I moved to Public Health Wales at the end of March, sneaked into Wales just about a week before lockdown to start my new role. And I remember having conversations in the early part of the pandemic, or when it was starting to be identified pandemic, with my own students when I was working back at Edinburgh Napier University. And I think then none of us could have foreseen actually what you were asked to do and the things that the way that you stepped up and kind of really rose to that particular challenge. So, you know, the first thing is to thank you all before we even start for how you've kind of, you know, shown that professionalism during this time. But I think one of the things that COVID has really exposed is the issue around nurses' health and well-being. I think it's now something that people are talking an awful lot more. We had the weekly claps for nurses every week, and now people are starting to pay more attention to this particular topic. But for some of us, Ben and myself and others that have been doing work on this predates COVID by quite a long way. And I think what we'd want to do just to start off with is kind of take us back on some of that journey over the last few years that I and others in working through some of this work have been on. And I'm going to take you right back and start back in 2016. And this is where we started when I was working at Edinburgh Napier University at the time, in the Nurses' Lives Research Programme with various different colleagues. There we started to explore the issue of nurses' health. And I actually started from a chance conversation that we had around whether we could use secondary data, the routine data that we have in our health surveys, to be able to answer questions about the nursing workforce. And the only reason that we can do that is because the nursing workforce is so large. There are so many nurses across the UK that when you start to look into those routine surveys that we all fill out, from the Scottish Health Survey, the English Health Survey, the National Survey of Wales, that actually you can then you can identify some, you can create groups of professionals within those surveys. So one of the questions that we started to look at that time was around obesity. There was an awful lot of discussion back then around that, about whether this was a challenge, whether this was a problem within the nursing profession. And what we did was we used the Scottish Health Survey to then estimate the prevalence of obesity across Scotland. And we did that and we published it in the International Journal of Nursing Studies. And from that point, there was a huge, as you can see on the slide, a huge press interest in this piece of work. And basically it was covered in every single Scottish newspaper, and there was editorials written about this particular point. And I think that one of the kind of shocking things that we found was that 69% of the nursing population, nurses within Scotland, were overweight. And if you looked at just those that were obese, then 30%, 29% of the nurses were obese within Scotland. Now that in itself was quite a staggering, surprising finding. But what was more surprising is we then started to compare nurses to other groups within the population. So we compared them to other healthcare workers, which was a group that included medics and midwives and allied health professionals. And we also compared nurses to the general population. And what we found there was that nurses were significantly more likely to be overweight than other healthcare professionals. And that in itself was the key driver, I think, to that kind of media publicity. But it wasn't just about a kind of splash in the press, it was also about actually impacting on nursing policy. And from that particular point, there was some great discussions and great action that I was involved in with others across Scotland through the Chief Nursing Officer. And the Chief Nursing Officer herself kind of put this at the heart of her nursing vision in Nursing Vision for 2030. And really in that document, published in 2017, there was a whole kind of platform in there around promoting nurses' health and well-being that recognised the work that we'd done examining overweight and obesity among nurses in Scotland. And this was really about actually starting to think about, well, not just what the problem is, but what can the solutions look like. From that, it was interesting because from that particular point, we then were engaged with in a piece of work, which was the Healthy Weight Initiative for Nurses, which was being led by colleagues down at London South Bank University. I say down, though it's really across from where I am now in Wales, but then it was down at London South Bank. And they kind of asked us to do an equivalent piece of analysis that we'd done in Scotland for England using the Health Survey for England. And so we did that piece of analysis, we worked with them on that. And what we found there, and we published that in the British Medical Journal Open, and what we found was that the kind of headline finding was that 1/4 of nurses were obese. Now, this was one of these really interesting things that then went everywhere. So this, you know, as a result of this piece of work, I was on the radio talking to Vanessa Feltz, although I didn't realise it was Vanessa Feltz that I was speaking to, and my wife had to tell me afterwards that I'd actually been speaking to Vanessa Feltz because it was all a bit of a rush. Nick Ferrari and Adrian Childs. And also it appeared, this statistic then appeared in one of these little books that you get at Christmas time with kind of facts. And that was the picture that's there. It's 1/4 of British nurses are obese, was in one of these little fact books. But then also there was a column that was written by David Mitchell at that particular point, which when my mum saw it, she was very unhappy with it. But I think that it's because he has a wee go at me, but that's what comedians are meant to do, aren't they? So he kind of suggested that that I had a career in greetings cards before I had an academic career, because I'd said as a result of the work that it's vital that we redouble our efforts to take care of our healthcare workers who do so much to care for others. And I still stand by that. I think that is absolutely true. But what he was kind of making the point about in this particular piece was that maybe we shouldn't expect healthcare professionals and nurses in particular to be any different to the general population. And I think that's a really interesting question that I've been asked a number of times over the years, and it'd be really interesting to hear your kind of thoughts on that via the Q&A as well. Now, just kind of in this kind of rapid sprint through how we get back to the present day, following on from that, we kind of did some work looking at the comparisons between the two, Scotland and England. And what we thought when we pulled this together was really that what we see is that the picture among nurses in Scotland was worse than it was in England, which raises all sorts of really interesting questions about why that is. And that's where we then started to think that through in relation to some of the work with the Chief Nursing Officer and others to try and think, well, what is it about nursing in Scotland that perhaps leads to these different statistics? So if you look at this graph, you can see here that the red is England and the blue is Scotland. And you know, other healthcare professionals, which again is that group that includes medics and allied healthcare professionals, there's not that much difference between the two. But when you look at nurses, there is a difference that emerges. And then obviously if you look at the non-health related occupations, is it something to do with the wider population health within Scotland? And that's what's accounting for some of the difference in that. When we look at obesity on its own, then again you can see that similar pattern in Scotland. So nurses, higher levels of obesity than we expected, than we found in England, but then also among unregistered care workers and other healthcare professionals too. So this raises all sorts of really interesting questions about what's driving this. And of course, this is just the prevalence stats. This is just the statistics about actually what do we see when we look at the data. It's not trying to unpick the reasons why. And that's still a really important piece of work and important discussion that we should be having. And as part of this work, in order to have that discussion, what I decided to do was to try and take this to the public, to try and engage with people about this issue. And so to do that, I did a number of kind of performance shows at the Edinburgh Fringe and the Edinburgh Science Festival, and also the Edinburgh International Book Festival, which is what you can see here. Really trying to take some of this work to people to try and ask their questions and get their views and get their opinions. Now, I think that was really kind of fascinating, because not just because of the experience of doing it, but when you start to share some of these stats, what you find is that the public are quite shocked. and rightly so, but there's also a sense of disbelief. So when you start sharing things about the makeup of the nursing workforce and the issues that are facing them, they do get quite concerned. And, you know, as part of the show, I shared stuff around the obesity stats, but I also shared some other wider statistics. Some of the things that I was sharing was some work that been done by the Cavell Trust that found that only 61% of nurses said that their health was good or very good, and that compared to 71% of the general population, so much lower. How there was a report actually by the RCN which found that 42% of nurses experienced stress and burnout. How the Sun had reported that 300 nurses have died by suicide in the past 7 years, which is a staggering 42 nurses a year, almost one every single week. And how the Nursing Midwifery Council's own data showed that nearly a third of nurses left the profession because their jobs were too pressured, meaning they were stressed, they had poor mental health, or both. And also how the #1 reason for sickness absence in Scotland among nurses is mental health. Now, as you'd expect, when I share these stats, people are rightly shocked. But as I mentioned, there's also this sense of disbelief. And during one of the shows that I was performing, I was in full flow in the kind of rehearsed kind of fashion that I was working through. And one of the people said, they stopped me in full flow when I'd said that nurses aren't able to take a drink in 12 hours. And they said, that's frankly ridiculous that that happens, and that they'd never heard such nonsense. And I was quite taken aback because I'd been interrupted, but that was until a student nurse spoke up in the audience. And they said they'd experienced every single last bit of it. They've experienced the missed breaks, the snatched snacks, and the thirst and the dehydration. And altogether, it painted a very, very poor picture of nurses' health. But as I mentioned, it's a picture of the problem and it's not the solution. Now, as a result of some of this work that I'd done at that time, some of the actual shows themselves were picked up by some journalists in the National. And Kimberly Hackett, who was at the, I think I've just lost the sharing screen, so I think I've lost the presentation there. Eileen, I think we can just see you in the presentation instead of the actual presentation slides. I'm not sure if that's right. I don't know if you want to. Not presenting. Oh, apologies for this. Let's see. Okay. Great. Okay, hopefully that's back now.
It is, Richard.
Oh, thank you very much.
Thank you.
I don't know quite what happened there. It seemed to cut out. Apologies. So yeah, so as part of that that work, it was covered within in the National. As part of the shows that I was doing was covered in the National, and one of the things that I'd kind of said to Kimberly at that particular time was that we should be making sure that hospitals promote health right from the start, that we have banned smoking across hospitals, but we still have nurses that are getting through 12-hour shifts, fueled on a couple of Red Bulls and a Monster drink. Of course, that made the headline. That was something that I said to journalists. You've got to be careful what you say to journalists. But I think what the key thing was that I said that it's about sending a message that health is a priority for everyone in the hospital, and that includes nurses. And this gets us closer to that aspect of the environment that we'll come on to in a moment. And one of the ideas that in response to this that I'd proposed was that we could think about how do we have protected breaks, protected meal times. One of the key policies within Scotland in particular was protected meal times. And that applied for patients, but did it apply for for staff. And I think that that was something that I'd kind of proposed, and then this led to a bit of a debate. I did say that it sounded like a bit of a fantasy within a context of a very stretched service, but I think that the commitment from the service would show that they do care about nurses being properly hydrated and being able to rest and refuel. And I did wonder whether this is part of the issue here, is about actually how do we solve some of these problems. And again, this is something I'd be really interested to get your thoughts and views on. Just following up from that, we did some other work and we started to think about actually what are some of the other behaviours that maybe underpin this. So again, we looked at the Scottish Health Survey and published it in the Journal of Advanced Nursing this time, and we started to look at actually what is the behavioural profile of nurses across Scotland. So what health related behaviours do they have? And what we found, just to kind of quickly whiz through the findings, was 17% of Scottish nurses smoke, 46% of Scottish nurses don't meet exercise guidelines, 68% of Scottish nurses don't meet fruit and veg guidelines, and 50% of Scottish nurses don't meet alcohol guidelines. Now, those in themselves, the statistics are quite shocking, but what we also found, again through that work, is that we did some comparison between nurses, other healthcare professionals, that group, again, that included the medics, included the allied health professionals, and also unregistered care workers. And what we found was that actually the health of care workers was almost across all of those measures was the kind of poorest out of all of those different groups. And that again was kind of picked up by the press at the time. And there was some really key things that I think that we were trying to push there. It wasn't that long ago now, but actually some of these really key messages that we wanted to try and share was really that care workers are providing this vital service. So one of the things that I'd said at that particular time was it also means asking harder questions about whether pay and working conditions reflect the value that we place on the vital work that carers do. And I think we've seen through the pandemic that is, you know, in terms of the impact that carers have had and the role that they've played, then actually we should have been supporting carers in a much bigger way before we went into this. And that we've kind of highlighted some of these key issues for the health of care workers now, let alone what the impact of this has been on care workers and other healthcare professionals. So I think we can pick that up. What I'm going to do now is I'm going to hand over to Ben, and Ben's going to kind of pick this kind of timeline up in 2020 and with a report earlier this year that Ben kind of authored and spearheaded this piece of work across Wales. So I'll hand over to you now, Ben.
Thanks, Richard. So yes, so this is the report that we published earlier on this year. It was meant to be published February time, but COVID delayed this. Surprise, surprise. So this piece of work sort of builds on what Rich has just been saying. In Wales, we've got a healthier Wales, which is our plan, which is between 2018 to 2030, is to get healthcare to flip, in essence, from one that treats people to more of a prevention sort of outlook. And at the heart of that is the well-being of the health and care staff, of which nursing and midwives make up most of this in Wales. So as a director, as an organisation, we built on some of the work that Richard had done and others in England and Scotland, and we looked at not just the health of the workforce in Wales, but also some of those wider determinant factors. So we're looking at their perceived feelings of their career, their perceived feelings of value, their working environment, and also some financial pressures. So how we did this was we approached the RCN and the RCM in Wales, and we mailed out email invitations to all of their members, and we also had the 10 directors of nursing from the health boards and trusts to cascade the invite to their staff. And the data I present here is from 1,600 nurses, midwives and healthcare support workers in Wales, which is about 5% of the workforce. Next slide, Rich. So I start off with just the general health and well-being of the workforce, and we have 71% that reported good health or better, 14% reported low mental well-being. And again, if you look at the health harming behaviours, there's 39% that said they were physically inactive, less than 10% smoked, 70% did not eat 5 fruit or veg daily, and 10% binge drink. I know that some of those numbers are pretty different to the ones that Richard just presented in his Scottish findings, but I think it was more to do with the way we looked at binge drinking, not saying that people in Scotland drink more than those in Wales. Next slide, Rich. But what does that actually mean for the nurses and midwives in relation to the general population? So in terms, in comparison to the general population, these are the latest national survey for Wales statistics. 70% of the general population said that they had good or better general health. So nurses and midwives in Wales are pretty much the same in terms of health there. Less were physically inactive, but in terms of the population, less smoked, less binge drinked, and less 76% of the general population in Wales do not eat 5 fruit and veg. So there's even less than that for the 70% of nurses and midwives in Wales. Next slide, please, Rich. And these are some of the environmental factors that we've gone on to that probably contribute to this 14% that reported low mental well-being. Of note, in terms of well-being, a higher proportion of those 18 to 29s said they found it really difficult to relax in general, not just at work, but just in the last 12 weeks. 62% of respondents reported workplace stress, half reported regularly missing breaks. Presenteeism was quite a big problem that we found, so that could contribute to low mental well-being. Financial worries played on a lot of people's minds, and there were lower levels of job satisfaction in some respects. And we'll probably come on to what these findings mean more later on in the presentation. Next slide, please, Rich. Yeah, so this is probably going on to the health more and being able to look after each other. So there's the presenteeism there. 61% of nurses and midwives attended work when and well. That was on 2 or more occasions. When thinking about looking after your health, 89% reported a barrier. Lack of time, no cover and service pressures were the main barriers. And those that reported poorer health outcomes actually were more likely to report barriers to health appointments as well. And the main issues of attending work when and well were stress and respiratory illnesses. So this is flu mainly, and 30%, so we go back to vaccination, and 30% did not have the flu vaccination in the winter season we asked. And some of the 2 main reasons were the fear of side effects and not believing that it works. So next slide, please, Rich. And in terms of the career progression, feelings about careers and value, over half people had considered leaving the profession in the last 12 months, but not necessarily acted on those feelings. Nearly 40% had considered decreasing their hours, and 30% had considered retirement. I know that's something not relevant for you younger students, but yeah, no one really wanted to increase their hours. It was all the other way. But in terms of feeling value, 80% of respondents felt valued by patients, and 70% felt valued by patients, by the families of patients. But there was a bit of a discrepancy there, that only 43% felt valued by the senior staff. Now, senior staff was up for interpretation. It could have meant consultants, it could have just meant line managers. So yeah, again, it's one of those things that is open to a bit of interpretation. Next slide, please, Rich. And when we asked about financial pressures, there was 3 different things that we asked. So we asked if any people had taken action to meet their living expenses. So this is basic living expenses. So this is food, warmth, and shelter. So cutting back on, and then to meet these, working overtime and borrowing money from family and friends are the main actions that were taken. If people had experienced financial difficulties, it was cutting back on travel and food costs. And even if they weren't directly impacted by financial worries, there was still that fear there. Losing sleep was one of the main factors that they'd experienced, and also some of the wider family impacts. So it's not just affecting the individual, but their household unit as well. Next slide, please, Rich. But it's not all doom and gloom. Even though I've provided you with not so positive outcomes, 75% of everyone still feel that their career is rewarding. 70% are also enthusiastic about their job, and over half would recommend their career. So there is something really to be said about that, I feel, even within the perceived negativities that I've just outlined there. Next slide, please, Rich. I think it's back to you now, is it?
Yep, thanks very much, Ben. So that brings us back to our kind of starting point, which is, you know, kind of whistle-stop tour of some of the research, some of the evidence that's been pulled together, as Ben shared, and some of the work that I shared around nurses' health and well-being. And I think what's really interesting is that was the context before we arrived at COVID. That was the situation before COVID, and obviously now there's an awful lot more work being done around COVID. But right at the very start of the year, what the World Health Organization declared was a public health emergency of international concern. And I think that word in the middle of that emergency is really, really key, because I think that's what we're facing in nurses' health. And I think we were facing that before COVID, and I think even more now we're facing it. An emergency, if you look it up in the dictionary, is a serious, unexpected and often dangerous situation requiring immediate action. And I think that's what the context actually requires. I think we need to be thinking much more about how do we support nurses. All of those quotes that were then twisted and said in the past about redoubling our efforts, I think we need to quadruple our efforts now to support nurses, to support you and your own health as you enter into this profession. And there's, I suppose, to think about, well, how do we get to that? What do we need to do? And there's a couple of different schools of thought around this. One would be that the answer is really to focus on resilience. And that sort of argument runs a little bit like this, that nursing is, and it always has been, a very stressful profession. Long shifts are hard on the body and mind, and vicarious trauma by witnessing death and distress is just part of the role. The lack of resources isn't going to go away, and the workforce pressures are only going to mount, and chronic workforce shortages mean the job isn't going to get any easier. So for nurses, for you to continue to provide high quality, safe and person-centred care, you're going to have to keep doing more with less, working harder, working smarter, working more effectively, keeping putting other people before yourselves. And that means that we just need to try and find ways to keep building nurses' resilience. And that's how we'll enable nurses to care, and that's how we'll enable nurses to cope. Now, resilience itself has experienced something of a resurgence in the wake of the workforce crisis across nursing. And the number of papers that have been published focusing on nurses' resilience has risen. The number of interventions being developed and tested to improve nurses' resilience has increased. And this is just if you kind of search and look for papers that mention resilience since 1963, this is the kind of exponential rise in papers that are focusing on that. But it's not the renewed attention on resilience that I want to challenge. Really, it's the assumptions that underpin this focus on resilience. You see, the challenge with identifying resilience as the solution is that it can inadvertently shift the focus from structures back to individuals. It can even feed into a culture that potentially blames individuals for not being resilient enough to cope. And obviously then to have various different behaviours in there that we've seen. And this focus on personal responsibility is not really surprising because it sits at the core of the nursing profession and the code of conduct that guides and governs professional practice across the UK. The first section of the code, Prioritise People, opens with the line, you put the interests of people using or needing nursing or midwifery services first. Patients come first. Section 20.9 of the code states that nurses need to maintain the level of health you need to carry out your professional role. Nurses are responsible for maintaining their own health. The standards of education that are used within universities to delivery of nursing programmes are no different. Section 1.6 states that student nurses should understand the professional responsibility to adopt a healthy lifestyle to maintain the level of personal fitness and well-being required to meet people's needs for mental and physical care. Earlier on in the document, it says that nurses must be emotionally intelligent and resilient individuals who are able to manage their own personal health and well-being and know when and how to access support. Personal responsibility for health is at the heart of the documents that guide how we practice as nurses and the mantra we preach to you guys, the nurses of the future. It's no surprise then that personal resilience is the response. If it's a nurse's personal responsibility to stay healthy, it is a nurse's personal responsibility to be resilient to the pressures of the workplace that potentially compromise their health, as we've seen in the statistics and the research and evidence that we've shown. But increasing resilience should not be our only response. Indeed, perhaps it shouldn't be our response at all. I think we've got a second option. There's one crisis that's facing our society that seems almost impossible to fix. COVID, I think, will come and it will go once we reach the point of vaccination. But it's not, there's another one, and it's just too big, too difficult, and too detached, and it's too late, and that's the climate crisis. It's beyond a crisis. We've declared an environmental emergency. And that's, as I've argued, what we're facing in nurses' health too. Concern for the environment has always been at the heart of nursing, one of its core concepts. And a couple of years ago, I wrote a paper with colleagues where we traced the history of the concept of the environment within nursing. Environment is a main leitmotif in Florence Nightingale's famous Notes on Nursing from 1859. Nightingale made early observations on sanitation and housing conditions in 19th century European cities, on the conditions, variation, arrangements, agencies and interactions in patients' rooms, and suggested how they might be managed to benefit health and care. Nightingale was at the heart of public health. Like most nurses after her, she understood that nursing incorporates a fundamental responsibility for the places that people reside. And then if we fast forward 80 years and the idea of nursing environment resurfaced within the burgeoning mid-20th century nursing scholarship as a core concept of nursing theory. In particular, nursing theorists wondered about what constituted nursing environment. This focus on nursing environment from Peplau, Henderson, Watson, Oram, all the names that you'll be familiar with or gain increasing familiarity with, and also others, was part of a zeitgeist for grand theories that would help justify, secure and build nursing as a legitimate profession and discipline, distinct and somewhat independent from medicine. But in recent decades, the emphasis on big nursing theory has declined, but interest in researching nursing environments has not. Research on work environments has burgeoned. Studies grapple with issues such as the support, the empowerment, the opportunity they provide or don't provide, or their social functioning, and what makes them psychologically healthy or unhealthy, or how their architecture and design features can impact care and outcomes. Similarly, nursing environment has also emerged in discussions of leadership capacity, such as settings for practice enhancement and development strategies through the work of McCormack and McCants. This diagram is something that you'll become very, very familiar with if you're not very familiar with it already, as contexts within political, economic and social variability that help or hinder research and knowledge translation from scholars like Rycroft Malone. Nursing environment has also been mobilised in debates on the best places to care, as in the case of institutionalised settings versus homes or homely settings, and through debates on the nature and importance of physical proximity and presence in caring interactions and relationships. And now, more than ever, we've seen that importance of that physical proximity in terms of those caring relationships and interactions. Natural environment too has become a well-trodden area of interest in nursing research, paralleling the emergence of the environmental movement. Whilst much of this work is locally focused and it's concerned with pollution and environmental health, some considers the impacts of health of a broader climate change and ecosystems change, and the role that nursing as well can play within that. Yet for all this recognition of the importance of environment for patients, for healing, for health, for recovery, for rehabilitation, for delivery of person-centred and place-sensitive care, we seem to have forgotten the fundamental role of environment in staff health. Statistics that we quoted earlier about obesity and smoking and hydration, nutrition, mental health, suicide should prompt us to declare an environmental emergency for nurses' workplaces. The workplace that produces these outcomes as a toxic byproduct should be the focus of our attention. More resilience will never be enough. Now, interestingly, at last year's RCN Congress, they debated resilience, and one of the delegates, Sharon Morris, stood up and she said, "Don't tell me I'm not resilient. I lack time and resources, not resilience." And reporting on that, Mimi Lauder in the Nursing in Practice, she wrote about the debate and reported on it, and she said that resilience is helpful on a personal level, of course, but not when it is weaponized. No individual is resilient enough to stem the tide of chronic underinvestment, unreasonable working conditions, and understaffing. And again, the important thing to emphasize is that all of this was in a pre-COVID world, which now seems quite distant and quite far away, but that was before COVID that this was recognized, the importance of nursing environments. And I just want to kind of pass back to Ben, who's going to kind of give us a bit of a summary of what's happened looking forward from COVID. Actually, some of the things that have been started to be written about in terms of what do those environments look like, what does nurses' health look like moving towards the future.
Yeah, thanks, Rich. Next slide. I think. There we go. So since COVID, so these are two reports that have just recently been published. I think both in conjunction with the RCN Foundation. One from the Society of Occupational Medicine, and again these are pre-COVID statistics. So the risk of burnout and stress higher than other jobs. It sort of just goes over what we have said previously. Workplace factors are the main source of poor well-being, so it is overstaffed, long hours, but there is also now the need to understand the impact of COVID-19 on mental health and well-being, and it should be one of those main priorities, and they're emphasising again the importance of taking breaks. The King's Fund have come out with 3 core work needs to improve health and well-being, which is the ABCs: autonomy, belonging and contribution. They argue that well-being is essential to the quality of care that is provided by nurses and midwives. And COVID-19 has just exacerbated these long-standing problems. So these problems, we've gone over them in this presentation, and they've just brought them back to the surface. And again, these main things familiar to everyone: stress, workloads, and lack of access to food and drink are some of the main drivers why people want to leave the profession. Next slide, please. And this is NHS Reset, and this is how for the next phase of COVID-19, I suppose it's getting the NHS, as it says, back on track. And again, staff wellbeing is the heart of it. Staff wellbeing of the NHS is paramount, and a review of burnout and the wider wellbeing is needed across the NHS. They acknowledge that we've got to support the exhausted frontline staff, and also again the mental health concerns of these staff, and it also needs to manage public expectation. We've had staff now from February, March rushed off their feet, and it's really important that the public's behaviour doesn't undermine the efforts, the hard-working efforts of this staff. And you've also got to think about what is possible with exhausted staff. People are just flat out, and they need that time to just regroup and refresh. Next slide, please, Rich. And I think, and these 5 actions here are 5 actions that we came to the conclusion with using some of the data that I presented to you earlier from my report, and also from the literature that was already out there, so it does include some of Rich's work, some of the RCN previous work, and we've got five sort of recommendations really we came up with, and the fifth one I think is mostly real relevance to you listening in now. Next slide please, Rich. So the first one is to address mental well-being in the workplace. Now, there is a real need to better understand the drivers of stress. Is it cultural? Is it workplace factors? Is it staffing pressures, or is it more than that? A potential solution could be something that we've so HEIW in Wales have come out with compassionate leadership, and that's got 4 components. Attend, which is give an individual time and listen, understand what and why they've come up, they're struggling. Emphasize, so care about them, and also help, give that support. And again, stress was highlighted in the RCN Foundation and Society of Occupational Medicine report. Goes back to, should we be enforcing these work breaks? Is it a cultural factor that people are working through rather than taking their breaks and looking after themselves? And again, it's more, our recommendations are pre-COVID, but now the COVID impact and workplace stress is likely to be a lot higher now, and it really should be something that we try to address. Next slide please, Rich. And we need to strengthen the prevention of ill health. So there was I gave it to you, presenteeism there was with nearly so many people coming to work when they were ill, and people need to be encouraged to stay at home when they're unwell, especially relevant now with any COVID-19 symptoms, and also to take care of people. One of the reasons that for people being off was flu or colds, and that's probably reflected in the low vaccine uptake. Only 70% taking up the free vaccine is for staff in Wales, and again, respiratory illness being that main reason for working when unwell. And we've seen a lot of things change with COVID. Telemedicine, video consultations in outpatients have been widely adopted. Could we do something in terms of future provision of occupational health and use that? And could that be more for staff? In Wales, we've got ambitions from Welsh Government to have 30% of everyone to work from home where possible. So workplaces have got the chance to change, and those workplaces that people are required to work at should be revolutionised to actually think about their staff, and there's the opportunity to do so. Next slide please. And I think it's important really to recognise and value the workforce. There is that big imbalance between the values that nurses and midwives felt in terms of patients and patients' family versus their senior staff. And again, those elements of compassionate leadership I went through in the first recommendation are relevant here. In Wales, we've got an employability plan. In Welsh Government, Fair Work Commission we have, and some of the components there were real and meaningful opportunities to progress, to adequately reward work done. There's some other elements, sort of voice and collective representation, a self-healthy environment to work in, and the fact that it's a rewarding career and there is enthusiasm to the job, even when we've reeled off those perceived negativities. And now there's a chance now. In Wales, we have Train, Work, Live, which is our recruitment strategy for the NHS. With vacancies still in the NHS and a looming unemployment crisis from COVID potentially, is there a chance now to attract new talent with transferable skills to help address some of those, to mitigate mass unemployment, and also to fill some of our vacancies within nursing and midwifery. Next slide please, Rich. The fourth of which is probably the most difficult one, which is understanding the root cause of these financial pressures. It really does likely require further research, and I know there are hardship funds set up for those struggling at present, but I think it's been doubled, or the numbers of nurses that and midwives that have applied for these hardship funds has just risen. And there probably is likely that these financial pressures again have worsened since COVID. Wider family situation, partner could have been furloughed or unfortunately lost their job. But I knew there's a new pay agreement on the line, so maybe in terms of that new pay agreement, I wonder if wellbeing could also be at the heart of some of those discussions, if they're not already. And next slide, please, Rich. So, and this is really relevant to the audience really today. So, the findings that we've outlined are more relevant and more the populations at risk of these poor outcomes are those 18 to 39 or within NHS pay bands 5 and 6. And there's elements of poor mental well-being, more financial pressures, highest proportion considered leaving, and the lowest proportion that feel they're valued by senior staff. And next slide, please, Rich. And why is this important, really? And I think it goes back to the fact that you and the younger members of the workforce are the future of the profession. They're integral to some of the Healthier Wales strategy that we've got. It's a 12-year strategy. We to lose that staff, we'd have to start at square one. And we need to really consider those long-term impacts of COVID on staff, the potential for post-traumatic stress disorder, and then we need to have a look at that, making that transition from student life to full-time work as smooth as possible. Next slide, please, Rich. I don't know, it might be back to you, is it?
Yeah, that's right. It's back to me. Thanks very much, Ben. Yeah, that's great. So I guess one of the key things there is really about, you know, how these are part of some of the solutions, potential solutions here. And one of the things that we did in response to this, to the work that we'd done previously, was start to think about, well, actually, what do student nurses, kind of, what do you think are potential solutions to some of this? I think it's good for us to be able to propose solutions and recommendations, but you know, you're living this now. You're going through your education at this particular point in time. You've just started your roles. You've just gone into practice, as I said at the start. You know, stepping up and jumping into the practice early potentially to do these roles. And one of the things that we did was we did a study with some of the student nurses at Edinburgh Napier University. We sort of thought, right, okay, we have all these various different studies. We've done this work now. What do they think are the challenges and what do they think are the problems here? What do they think are the causes of some of these behaviours? Trying to understand the why, not just the kind of what we see. But then also, more importantly, what are the solutions? So we did a really neat little study, and that's just been published this year, actually. And you can have a read of that if you're interested in it. And that really focuses on a kind of novel approach where we created causal trees. So we tried to create these kind of tree-like structures where you can think about, actually, this causes this, and one particular factor has an impact on another factor, and trying to understand what do student nurses themselves think are the factors that interlink and cause this kind of behaviour at the heart of it. But then moving through that, through a very series of participatory activities, to starting to think about, well, what are the solutions and who needs to be part of the solution? Because I think that's a really key question there, is like, where does the solution land? Who owns that particular solution? So here's an example of some of the things that we did. These are some of the very simple exercises, and I think they're exercises that's really useful. You know, if you dig out the paper and have a look at it and try and maybe do it yourselves, or encourage each other to kind of look at this activity just for your own health and well-being in your own campuses and in your own practice settings. And what we then did was kind of pull this all together and then started to think about this through the kind of COM-B model of behaviour change. And this has been, of course, something that, if you're following any of the behavioural science work that's ongoing at the moment through the pandemic, you'll be very familiar with people like Susan Mickey and Robert West and others who, you know, were at the forefront of developing this model, and that it's being used in order to try and inform some of the messages, or trying to influence some of the messages that are around COVID in terms of public adherence to various different behaviours. But this model predates all of that and is really useful for us to start thinking through some of these issues. And what we found when we spoke to students was that a lot of the solutions that they proposed to us could be categorised under the environmental restructuring intervention function of the COM-B model. And they thought through 7 key solutions. They thought that one of the key things was about reviewing shift work, making sure that actually are 12-hour shifts too long? Should shifts be shorter? Should they be different, organised in a different way? Improving the workplace support and the leadership, and I think this comes back to a lot of what Ben was saying there in terms of feeling valued, and then the support and those supportive structures that are there in terms of compassionate leadership to try and support people in their roles. The third one about increasing staff levels, recognising that actually there's not enough people, and how do we increase staff levels? How do we encourage more people into nursing? How do we encourage more people to stay in nursing? The fourth one around subsidising healthy food and exercise through gyms, through canteens, through facilities like that, but not just, you know, out off ward environments, but how do you bring sort of hydration and hydration stations into wards? We heard stories in terms of some of our work that we've done about students, and they talked about it in this study as well, not being able to fill up their bottles of water after a certain time on a particular ward. And it's sort of things about how do we challenge some of that? How do we encourage some of that to not be happening? The fifth one around promoting peer-to-peer activity and role modelling, and Ben will pick this up in just a second, is a really key one. Exactly how do you come together as students, as newly qualified nurses, to actually role model some of the behaviours and actually start changing things from the inside out? And then also integrating lifestyle advice. This is more around education into nursing education, maybe changing some of the curricula, and these last two are really focused on some of the nursing curricular aspects, changing maybe lifestyle advice into nursing education, but also time and stress management training as part of nursing education. And I think these are all really quite key kind of things, because these are the things that have come from students, and it's not about us kind of looking at the evidence and thinking through the evidence, but actually it's about putting the evidence to students and thinking through some of these solutions. And again, it'd be really interesting to hear your comments and your thoughts on what you think are some of the solutions through some of the questions potentially, but then also by engaging in discussion on Twitter and elsewhere about what you actually think would work. We've promoted quite a lot of things or suggested things like protected meal times and these kind of things, so it'd be really interesting to hear your own thoughts on this. I'm just going to hand over to Ben, because of course in this promoting peer-to-peer activity and role modelling, one of the key things is about how do we actually have conversations about health with patients, but then also with each other. And I think that's kind of a challenging thing. So we've started to do a wee bit of work, and this is kind of hot off the press stuff that we've been doing at Public Health Wales. So it'd be interesting just to pick up on some of that to trigger the discussion. So I'll hand back over to you, Ben.
Great, thanks again, Rich. So yeah, this is hot off the press. We haven't published this yet. We're looking at really asking topics of conversation. So in Public Health Wales, we pushed the Making Every Contact Count agenda, and we asked really in our survey, how many of you feel confident and comfortable in discussing health harming behaviours with service users all of the time? And less than 50% of respondents reported that they feel comfortable. Smoking was one of the topics that they found easiest to talk about, and the one that they found most difficult was discussing healthy weight. The other topics we asked were physical activity, diet, and alcohol, and that was around the 38% mark for all of those. And again, it's the lowest proportions in the 18 to 29 year age group and NHS pay band 4 and below. So I guess one of the things there is there something that needs to be introduced in the curriculum to help this, help you engage in conversations in the workforce when you're in the workplace with patients and service users. The main barriers we identified was no time to discuss, so take that away. But then when we think about the environment, it's having no suitable space and also feeling worried about upsetting those patients. They seem to be the biggest things. But the fourth reason was thinking it was hypocritical about your own healthy behaviours. Next slide, please, Rich. Yeah, and thinking about that then, those that said they had good general health were more likely to engage in topics apart from smoking, and those with average mental well-being were more likely to engage in all topics. So it's the importance of looking after yourself so that you can then look after the service users. And in terms of health harming behaviours, those that were to engage in physical activity and healthy weight conversations, if you were physically active yourself, you were more likely to engage in those conversations. And if you healthy eating, so in terms of getting your 5 fruit and veg a day, you are then more likely to engage in conversations about diet or weight yourself. So yeah, it's taking that forward. So the importance of looking after yourself can then look after the population. I think that's it, Rich. I think it's back to you, is it?
Yes, it is. Yeah, thanks very much, Ben. And I think that, I mean, that kind of point there is really key, because it's how does what we've been talking about link together? How do we think about our own personal health and the impact that that has as individual professionals, but then also on the profession? And I suppose part of the challenge with this is that, you know, we've tried to present a kind of overview of the statistics and of the research and the evidence and how we went about doing that, and then also some of the potential solutions. But I think that one of the really key things in all of this is that even though this can seem like it's an emergency and it's potentially overwhelming, actually, in terms of what we can do, one of the really key messages is that lots of small actions by lots of people can lead to quite a big change. And one of the reasons why kind of push myself out my own comfort zone and started to stand on a stage with no PowerPoint and no slides and no I had a few props, and then take this to like a fringe show or the international festivals to start conversations about this. And I think that that's why it's great that we've been invited to this conference to be able to have this conversation, because that's the sort of conversation that I hope that you'll be able to start having with each other as students, as newly qualified nurses, with people who you're working with and working alongside. Because I think that, you know, having those conversations, it's hard to have those sort of conversations, as Ben's just presented, with patients, but sometimes it's even harder to have those conversations with each other. And so I think that sparking that conversation can actually make a big difference. And I think the real powerful illustration of this is that when we think about somebody like Greta Thunberg, you know, who sat alone outside the Swedish Parliament on a school strike with a single placard, and then, you know, a year later, you suddenly had a whole movement across the world joining with Greta to be able to say that actually this is something that we need to focus on, the environmental emergency for our planet. And I think that the same thing that Greta said around the environmental emergency for the planet applies to the environmental emergency for nurses' health. When she was in Davos, this is what Greta said. So Davos, surrounded by the kind of great finance ministers from all around the world. Our house is on fire. We all have a choice. We can create transformational action that will safeguard the living conditions of future generations, or we can continue with our business as usual, and that is up to you and me. Now, I would argue there is no business as usual anymore. I think COVID has changed things fundamentally. It should change things fundamentally. Ben mentioned about how telemedicine, video conferencing, all of this has completely changed the way that we do things. It's changing how we deliver this conference. I think it will change nursing practice as well. The way that change goes is up to you and it's up to me. And I think there's two key things that we really want to kind of end with, really, and two kind of key messages actually. And the first one is really going back to that point that we were making about, you know, putting others before yourself. I think particularly during this time, you know, actually putting yourself before others is actually the way that you can protect others. You know, I think that it's the powerful demonstration of that is in how we all adopt our own particular behaviours to support others to stop the spread of COVID. And I think that's about, you know, making sure that we put our own life mask on first before we can then care for others. And that message is so fundamental in all of this. And I think that applies, again, we use this phrase now more than ever. It's kind of becoming a bit of a COVID cliche, but it's absolutely true in this space, because it's about, you know, actually how do we support other people if we've not also looked after ourselves. So I would plead just to look after yourselves through this time, and that's a good way of supporting your own health. The second thing, and I want to finish with these kind of remarks, and they're not my remarks. These are comments that were made by one of my students when I was working up at Stirling University in Inverness, and he'd had a particularly challenging placement experience, and we had a very, very long, frank discussion around about Christmas time one year. And he was considering what do I do next, and we had a really good discussion. And then what he did was he wrote for the RCN bulletin. There's a little section in there which is students can get to write from the heart. And this is what James wrote. He said, as nursing students and newly qualified nurses, and I've added that wee bit in, we can play a unique role in bringing positivity, freshness and enthusiasm into practice. By embracing this, expressing ourselves and speaking up, we may just empower others to be the change they want to see. And I think it was really interesting that he phrased it in that way, that we might want to see change, but actually others might also want to see that change too. And that by us as students and as newly qualified nurses, speaking up, being positive, being enthusiastic, believing that we can make things better, they might actually obtain the change as well that they've always wanted to see as well. So I just want to finish with those remarks and just say thank you very much for listening and all of your attention, and I look forward to your questions, and we'll try and answer those as best you can. I've also popped some references here to the various different studies with some links if you wanted to dig into those in a little bit more detail. And of course, just to share our contact details as well if you wanted to reach out and get in touch. But thank you very much for listening. Thank you all for your attention.
Thank you, Richard and Ben. That was a really thought-provoking presentation. It makes me wonder how I've managed to survive nearly 40 years of nursing, and I don't often confess to that. So some questions are coming in. As students starting out on their career, how can you protect ourselves from the issues you describe?
That's a really great question. No, I think it's a really, really important one, I think. And I guess it comes back to what I was just saying there in the way that I think it's actually about having those conversations. And I think there's ways about having those conversations in quite a structured way. So as Ben was kind of going through some of the compassionate leadership things, I think actually having some of those conversations, making it part of what we do, making that actually part of the business as usual, by making sure that we're actually, when we're leaving placements, you're speaking to each other, that you're taking some of those questions back to the folks within the university that are supporting you, that you're having those sorts of conversations about your health. So often those conversations revolve around the doing of nursing, actually what you're doing in your practice, how you've fared, how you've done, what competency you've managed to meet, and less about actually the being of a nurse. And I think that's really, really important to be starting to talk about actually what does it feel like, how is it being experienced by you, having those sorts of conversations and then supporting each other through some of that. And I think it all comes down to the openness really and the honesty that we have with each other about our health. And I think now, particularly our mental health, I think because particularly now it's a very, very challenging environment. And I think that has lots of impacts, just the idea that we're kind of moving into various different lockdowns. In Wales, we're going into sort of a fire break for 2 weeks. This has an impact on everybody's mental health, and nursing on top of that is obviously going to be challenging as well. So I think the key really is to talk to each other and to listen and then to support each other, I think is a really fundamental part.
Great. So you talked about understaffing and underinvestment. Do you see any indication that these issues will be addressed? Another really good question.
Ben, do you want to pick that up from your perspective? And I can.
So, I think I sort of hinted towards that with the understaffing issue, in terms of there is the opportunity now to retrain. For an example, that the airline industry is one of those industries that is probably going to be hit more than most from the COVID crisis. And me and Rich talked about it, and there are a lot of transferable skills within airline staff, caring, service sort of based professions that can be transferred to the healthcare profession. So in terms of that, it's making the opportunities that people can just, I suppose it's advertising a career in health and care that isn't probably through traditional means. Employment is important to people. Employment and health is such a long-standing sort of relationship. It's important to have good work. So in one crisis could lead to in one industry with jobs could actually help us in the health and care industry to fill some of those vacancies that have stayed vacant for so long.
I think I'd like to add that both Wales and Scotland are in unique positions to have safe staffing legislation.
Absolutely.
And I think every nurse and student needs to make themselves aware of that legislation, and being politically aware is something that we all need to do as professionals, and it's about using the legislation to highlight the chronic understaffing. It's not enacted yet in Scotland. It's been passed in Parliament, but COVID has delayed the implementation. But we are pushing really hard to the Scottish Government to get that legislation implemented. So yeah, use the tools that you've got to highlight the issues. And I'll put another plug for SenseMaker. Give us your stories so we can use these stories to highlight the issues. Another question, why do you think Wales appears to have a higher job satisfaction and better wellbeing habits compared to Scotland?
It's a very interesting question. I think one of the challenges, I suppose, with all of the research, and this is something that we need to think about moving forward, actually, is how can we enable this research to be truly comparable? So I think we've got to be very, very careful when we're looking at the kind of comparisons across countries. And this did come up actually when we're looking at the comparisons across Scotland and England, and then also when you look at it in Wales. So I think Ben and I are having conversations about how can we actually use data in a particular way to try and bring some of that together so that we've got a UK picture which would enable some of these comparisons. So I think that's the first point, it's about we have to be a wee bit cautious when we're comparing between different countries. And I suppose the second thing is around the context and trying to understand the differences in the context. And that's something, again, that we probably haven't necessarily, or we can't necessarily kind of capture some of that unknowns in the data to be able to then say actually this is definitely a difference in between the two countries. So I think we're at quite I think there are mechanisms, and we have been chatting about different ways that we could look at doing these UK-wide studies. And I think some of that actually, in an odd way, COVID has actually probably supported some of that in terms of being able to think about data and how we use data more effectively for the workforce, to be able to really try and draw some of these comparisons. I don't think there's anything. I think the other thing as well is a question of scale. So when you're talking about Scotland or you're talking about Wales, there's a huge variety within that. And again, these are just quite kind of high level national statistics, but when you start digging into it, you can actually see a lot of variability across particular boards, we've got boards in Scotland and Wales, but in terms of the kind of geographic boards, and it's actually trying to understand some of that at that level. But the challenge with that is that you need higher numbers in your studies to be able to look at that. So if we had some mechanism, which again trying to explore, to be able to capture or understand the experiences of all nurses in some way, then actually that would allow you to do that kind of fine-grained analysis. So I think that's more of a methodological answer really but I think it's important that we raise that.
Yeah, I agree with Rich, really. It is the data that Richard used was from national surveys, existing data. We had to collect the data ourselves, volunteered really. Those people that wanted to fill in the survey were probably happier in their career. So that it is really difficult to make those like-for-like comparisons. So yeah, so it is. If we had a UK data, we would be able to make those comparisons, but maybe that's one for the future.
That's one, yeah.
Okay, a couple of comments. It is really interesting, as someone who was an incredibly active student, it is now really incredibly hard as a newly registered nurse. Interesting you mentioned Greta and her circle of concern in relation to climate action. I find this can often become overwhelming, and we have had so much to take on board, adapting to our new roles, that it is often more practical to focus on our circle of control and what we can actually impact on a daily basis. Also, I would be lying to say that COVID-19 hasn't made the world different, and I am now deeply worried about the emotional labour of nursing and post-traumatic stress disorder. We really need to be addressing this, and I think the RCN has a large part to play in this. So I think that's probably for me to comment and say I absolutely agree. I think the RCN has been working really hard to highlight the issues of the emotional labour of nursing, and I would commend the report that was mentioned, the King's Fund RCN Foundation report that was mentioned. I read that the other week, and I just thought it was a fantastic document, pulling together a lot of issues into one document. The downside of that was I was a bit disappointed because these issues have been debated and discussed for about 20 years, and I'm probably being generous there. So I think it is about a call to action, and using your analogy of Greta, there are a lot of nurses out there, and together we can be really powerful and strong. I noticed on Twitter a comment about, and Craig, I hope you don't mind me mentioning your tweet about resilience, and I'd just be interested in what you think about how we could change the focus from resilience being used as a weapon to beat people with. You know, if you raise your hand and say we're short-staffed, we're not coping, you know, we've heard of nurses who are put on, no, well, you just lack resilience, you need to go on resilience training. So how can we shift that focus to one where there is a culture where everyone is psychologically safe to raise concerns or put forward ideas for improvement?
Yeah, I mean, I think that is really to pick up on Craig's, but I think that is the fundamental shift that has to happen here. I think we kind of, you know, for the purposes of argument, we made it sort of a sort of oppositional thing between resilience and environment. I think the two are much more intrinsically linked. I think if you've got, and to be honest, for me, I think it comes down to leadership. But not necessarily leadership that's kind of formal leadership. I think everybody within healthcare organisations is a leader, and I know that's again another cliche, but I think it's about, you know, doing all the things that leaders do, finding the allies to get things done at every level. You know, to be able to collectively come together to try and find, you know, to try and create that voice that can then make those changes. I think it comes back to some of the things that James was saying about actually, you know, having the courage, actually, and that's a word that's really coming up time and time again, actually, the courage to be able to say, no, that this is not making me psychologically safe to be in this environment, and trying to push back against some of that pressure that's come in there, and actually to be able to stand up and have that, and then to find the allies who are going to support you within that. Because I think that, you know, but then also I think at a more senior leadership level, I would hope that this period has really been an awakening, because I think one of the greatest allies that nurses have always had, nurses are the most trusted professional if you ask the public, and I think the greatest ally that nurses have always had is the public. And I think, you know, we've seen that over the last few months in terms of the, you know, the outpouring of support for nurses, and it's about how do we keep talking about, how do we keep that in the agenda, that actually this issue is fundamentally important, and whether it's through small actions about, you know, I mean, like tweeting and constantly talking, bringing back the conversation, stepping out of your comfort zone, going talking about it to different audiences, you know, forming groups within the student community to then advocate for some change within the curriculum or within the campuses, and all of these kind of things, and having the courage to be able to do that. I mean, as my time as a nurse educator before I moved into Public Health Wales, you know, it was often through the actions of, you know, one or two students that could then bring people together that made some really fundamental change. And I think that can, and so I think I would just, you know, almost encourage Craig and others to really try and to bring those people around you to then try and make that change and push that change forward. And I hope that answers the question. I'm quite happy to have a tweet chat about it as well. But definitely.
Yeah, I think your comment about leadership is absolutely true. And interestingly, last year's students' conference was about students as leaders. So yeah, good link there, Richard. Thank you. I've got another question about resilience here. So it's on the same kind of theme, and it is, what is needed to demonstrate that the structure needs to change? So how do we do this? How do we change structures and cultures? I would add in.
I mean, that's very, very challenging. I think, but I think it's about trying to identify what are the levers through which you can do that. So I suppose actually engaging with RCN, that's one particular lever. But you know, everybody is, you know, everyone is political to some degree. I mean, we all are political beings, and we have our, you know, members of Parliament, members of Scottish Parliament, and all these kind of things. It's about engaging at that sort of level as well, actually, in terms of being able to engage with some of these issues and keeping them at the forefront. I think in terms of, you know, challenging the over focus potentially on resilience, it's probably about starting to actually, you know, keep track of the way that the environment does shape your own health, to keep track of some of those things. A lot of the kind of questions that came to us are about, you know, from students actually telling us that, you know, the example I used about, well, you know, in a particular ward, they weren't able to have a drink after 4 o'clock, even though they were running all the way through to, you know, through later on in the day. So you think, well, actually, no, then we have to think, well, how do we act on that? How do we as educators act on that? But I suppose it does come back. I'll make another link to the RCN stories. It's actually about trying to link the stories together. It's about thinking actually, what are the stories of working in this environment that's really key, and building some of those stories up so that we can actually start thinking about how does the environment impact on students' health, on newly qualified nurses' health. And then focusing on that, which will kind of tip the balance, I think, in terms of environment in many ways. But it's also kind of about challenging some of the other kind of structures. So having, you know, and this is something that I would think I'd really encourage students and newly qualified nurses to think about. And I think that comment that was made about, you know, sticking within your circle of control, and I think that's right. I mean, but nursing is one of the amazing things, and this is something that Fiona McQueen talks about an awful lot. Nursing is an amazing career in the sense that you can be a nurse for a very long time and move between different settings. It's one of the wonderful things about nursing. But in doing that, you know, it's fine to take your time to find your feet within nursing, to find, you know, take the time to transition into nursing. You don't need to know everything all at once, but it's kind of actually having that idea about where do you want to go, where do you want to get to, and thinking about where do you want, and then trying to then broaden out that circle of control into the circle of concern, into the circle of influence, and then you starting to have that particular impact on the environments around you through kind of, you know, going for those leadership positions, you know, trying to go for the next job up when you want the next job up, and you know, having the courage to do that, even if you think that you're going to take you might not get there. It's fine, you know, just keep going and trying to do that, because I think that will ultimately change the environment. Because I think this period that we're living through now should fundamentally change it, and actually it's the people who are listening right now that will change this stuff. It's not necessarily in my hands or Ben's hands or even Eileen's hands necessarily. It's in the collective hands of students and newly qualified nurses as they move through these careers.
Okay, probably a question for Ben. On your recommendations in your report, you talked about reviewing shift work. Now, interestingly, one of the sessions next week is about how to maintain your well-being while working shifts. And we know there's lots of debate about length of shifts, you know, 12-hour shifts, 8-hour shifts. I suppose it'd be interesting to know what your thoughts are around shift work and what that review and shift work should look like.
I guess it's not, shift work is part of the job really, and I don't think that will ever change anytime soon. I think it's the recovery from the shift work which is more important, and taking that time for yourself to actually recover and refresh and reinvigorate yourself properly, and taking that time that we've said well-being is important. It's all the way through the findings that the research that we've done is that personal well-being. It reflects in yourself, it probably reflects in how you feel about the job, it probably reflects on the quality of care that you give to the patients. So I don't think it's one of those system things that may never change shift work, but I think it's more to do with looking after yourself and looking after others, and just taking that time to say, as you say with mental well-being, isn't it now, it's okay to not be okay, and that is everything. So I think you look after yourself and everything else will fall into place, really.
Okay, I think we're almost coming to an end today, so it's down to me to thank you both for taking the time out to share your research and your thoughts with us. I think I have found it absolutely fascinating, and I know by some of the comments that are coming in, somebody's commented, I have found this so interesting today, and I feel I try my hardest to make changes that is needed as a student nurse, but sometimes it's hard to know. It does not take one, but it requires an army. I would just like to say you are an army. Your collective voice is really loud. Let's hope as a student and a newly qualified nurse we can make these changes and be heard. Thanks again, gave positive energy today, and we'll take this on board. So I think that's a good place to end the session. So I'd like to thank you both and the audience for joining us today, though we can't see them, but we know they're there. And again, for the audience, we have another 2 sessions that, you know, I really hope that you join us, and the debate around the future of nurse education. And as the one I mentioned about shift patterns and how to maintain your well-being while working shifts. So once again, thank you everybody, and look forward to seeing you all at our next events. Thank you.